So good morning, everybody. Happy Thursday. Happy May 9th. Hopefully everybody's doing well. Appreciate everybody taking time. We're going to spend about the next hour talking about a very important topic, substance abuse in the workplace. I think everybody's aware that May is Mental Health Awareness Month. Very important. I could tell you when I talk to our members since COVID, you talk about mental health and you talk about burnout. It's not just in the healthcare industry, and I know everybody in the healthcare industry really were the first responders, and we saw it firsthand there. But whether I'm talking to an accountant, a banker, a lawyer, a manufacturer, everybody's doing more with less people. People are all working remote sometimes. The work week has gotten like just shattered work hours. I mean, everybody's working all day long, early morning, late night. So I think today is very important. And the way we want to do this is we got about 8 or 9 speakers, but we're going to handle it in a way where we want to keep it informal, conversational. We're going to break it up into 2 parts. The first part is for a company, your HR professionals are very important in terms of what are you allowed to do? What are you supposed to do? What's the best practice in terms of if you have an employee going through something, how to approach it. So we're going to start from the legal HR perspective, and then I'm happy to say the second part is really, offering treatment services and options that are available through our members and through our healthcare professionals. So again, thank you, everybody. And I want to acknowledge our chairwoman, Audrey. Deb is on our board. So, appreciate everybody being here. With that, I also want to thank Nicole DeMaria because I know she's on our steering committee. And this is a topic that she brought up from CSG. She's a team leader in healthcare and hospitals there at the firm. She did a great outline, and she's going to kind of kick it off. And again, the only thing I ask is that please, if you have a question, put it in the chat box, unmute yourself and ask, because again, we want to keep this conversational. So with that, Nicole, good morning and thank you.
Hi, thank you, Tony. Thank you, everyone, for participating. I head up the healthcare law team at CSG. So I provide healthcare regulatory and corporate transactional counseling to healthcare providers, including behavioral healthcare providers of some of you, of the type that are some of you are on the call today. So I'll be providing some statistical and other foundational information that I think really helps to set the stage for our discussions. Before I begin, I just want you to know, and I really do appreciate that we're having this conversation. Candidly, I lost my younger sister to substance use disorder. She struggled with this disease for over a decade. And unfortunately, it seems like I'm learning about more and more people who have had similar experiences. And the statistics sort of support what the statistics I'm going to show you sort of support that the numbers are not going in the right direction. So it's really important that we have these conversations because the stigma is a real barrier to treatment. And these types of conversations will hopefully improve those statistics. So again, thank you so much for just joining and participating in this. I personally appreciate it. So I'm just going to share my slides. Just give me one moment. Okay. So you should be seeing that, right?
Yeah.
Okay. So first let's start with what is substance use disorder. So this is how it's defined by the National Institute of Mental Health. It's a treatable mental health disorder that affects a person's brain and behavior, leading to their inability to control their use of substances like legal and illegal drugs, alcohol, medications. Symptoms can be moderate to severe, with addiction being the most severe form of SUD. So then we move into, well, what is addiction? This is from the National Institute on Drug Abuse. It's a chronic relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful consequences. It is considered a brain disorder because it involves functional changes to the brain circuits involved in reward, stress, and self-control, and those changes may last a long time after a person has stopped taking drugs. So I found this video. I thought it was very helpful, at least from my perspective as a layperson, not a medical professional. I think it does a good job of summarizing really what the effects that this has on the brain and why we should not view this as a matter of willpower. So I'm just going to stop that and I'm going to share the video. I have to catch. Okay. Sorry, all the windows are confusing. Having a computer problem. Hold on. I'm so sorry. 1 second. I am solving it right now. Okay.
Okay, there you go.
Yeah,
So,
sorry. Okay, here we go.
thank you.
Addiction is defined as not having control over doing, taking, using something to the point where it could be harmful to you. Previous to understanding the science, it was thought that addiction resulted from a lack of willpower and was a moral failing. But we now know that addiction is a physiological disease. It changes the brain structure in ways that can alter the way it works and process information. To understand how that happens, we start by thinking about reward and the brain's natural reward system. The reward pathway's primary function is to reinforce sets of behaviors. Evolutionarily, it began as a way to indicate to us that actions that help us survive are good and we should keep doing them. This is mediated through a chemical called dopamine. Following an appropriate behavior, the reward pathway releases a small burst of dopamine. That burst of dopamine is a satisfying jolt, encouraging you to repeat the same action in the future. Dopamine will in turn also act on areas responsible for memory and movement, which helps us automatically build up memories for what is good for survival. The problem is that addictive substances hijack our natural reward system. Every substance has slightly different actions on the brain, but one thing all addictive drugs have in common is that they produce a pleasurable surge of dopamine. Addictive drugs all cause dopamine to flood the reward pathway 10 times higher than a natural reward would. Over chronic use, nothing else natural is quite as rewarding. In fact, as substance use increases, the circuits adapt and reduce their sensitivity to dopamine, a phenomenon known as tolerance. For example, let's say a person takes cocaine for the first time. The reward system receives a huge burst of dopamine. But as the person takes more frequently, cocaine will be overstimulating the brain with dopamine. This will cause the brain to adapt to these chronically high levels of dopamine. To compensate and adapt to this new normal, the brain reduces the number of dopamine receptors available in the reward system and releases less dopamine. As a result, that person will feel the need to increase the amount of drug they take so that they can reach the level of high that they're used to. But it's not just the reward system that's affected by this tolerance, since dopamine is also involved in other brain mechanisms. Other brain regions involving decision-making, memory, and judgment also get physically disrupted as a result. The overall effect is to have drug-seeking behavior driven by habit rather than conscious thought, like a reflex instead of a choice. This biological basis helps to explain why addiction really is a brain disease, not a matter of willpower. The stigma that accompanies addiction only makes seeking treatment more difficult.
Okay. I'm going to go back to my PowerPoint. Sorry, it's never as easy as you think it's going to be. Okay. Okay. So as you can see, that our science has instructed us better on these issues. We can see that there are real effects on the brain, and we're just beginning to understand these things. The current slide I'm showing you, again, another thing that sort of shocked me in terms of what happens to the brain. You're seeing the dopamine receptors and in a normal subject, and then looking months after you've stopped using the substance, there's still these long-lasting effects. The dopamine receptors are just not firing. And from my understanding, it could take a year or longer for things to really, especially for someone who has been a long time user, it takes a long time for things to start to normalize. So you have to understand that also, that this is not a 30-day rehab stay is not going to necessarily going to fix this. This is a chronic disease that we have to treat like a chronic disease, like any other chronic healthcare disease, like heart disease or diabetes. So here are some of the statistics. So this is from the Substance Abuse and Mental Health Service Administration. They do a report every year. So these statistics are based on 2022. A new report for 2023 should be coming out soon. So nationally, we've got about 17.3% of people that have SUD. Of those classified as needing substance use treatment and received it, only 1 in 4. Or of those who did not receive substance use treatment in the past year because they did not think they need it or should get it, that's most people. And percent of adults with SUD who sought treatment, only 0.8%, and those who did not seek treatment but thought they should get it, 4.5%. So those are not good statistics, obviously. This is specifically for New Jersey for 18 and older, those who received substance use treatment. Those classified as needing it, 1.2, almost 1.3 million, but not receiving substance use treatment among those who need it. Again, most. I mean, those are astounding numbers to me. Obviously, we have to change that. And this is showing you how we are comparing to other states. So we're, in terms of classified as needing substance use treatment, we are in the 15 to 18% range. Relative to other states, maybe not so bad on the lower end. Did not receive substance use treatment in the past year, age 12 and older, but among those classified as needing it, we're in the middle of the pack there. And then these are statistics from the Department of Human Services, Division of Mental Health and Addiction Services, showing you the trend of treatment admissions. And interestingly, you can see in 2019, it spiked. I assume that's because of the pandemic. I've always heard that, we had increased issues during the pandemic. This is by primary drug. Obviously, alcohol and heroin are the biggest proportion here. And again, you can see the spike in 2019. And these are the various types of admissions and level of care. And our second panel will be speaking to that and the types of treatment options that you have. And this is by age group. They're age 35 and older are the biggest proportion here of treatment admissions. So the impact of substance use in the workplace, it's significant. And that's why employers should really care about these issues. The majority of Americans with SUD are employed, predominantly full-time. SUD in the workforce is costly, resulting in absenteeism, productivity losses, increased healthcare costs, elevated liability exposure. Workers with SUD take nearly 50% more days of unscheduled leave than other workers, and an annual turnover rate of 44% higher than the other workforce. And by contrast, workers who are in recovery from SUD average nearly 10% fewer days, and the turnover rate in recovery is 12% lower. So again, this is obviously advocating for treatment. And turnover is extremely costly. Recruiting and training replacement worker costs approximately 21% of the employee's annual salary and benefits. And there's this helpful tool at this website, Employer Substance Use Cost Calculator, that I actually plugged in my own numbers just to see what would happen, just to see. So I put in New Jersey, 200 employees in the professional management and administration industry, and that's what I got back. Don't know how accurate that is, but it's just sort of just to give you a sense here. These are issues that employers should be dealing with, and it is in their interest to advocate for treatment and have these conversations with their employees. And just from a personal note here, I don't know whether these numbers take into account productivity lost by family members. And I could tell you, family members suffer from this disease as well because it's so complicated and the ripple effects are so severe, can potentially be so severe. So it was just a point to make here. I mean, this is not a disease that affects one person. So, what can we do? Obviously, like I said before, just having this conversation is a huge first step. The stigma and the shame associated with treatment and exposing oneself as someone with SUD is very damaging, and it just delays the treatment that people really need. And with other medical care, and again, this is healthcare. Early intervention is key. It always is. I can't imagine an instance where it wouldn't be important to get in there earlier. And the brain effects from SUD are going to get worse over time. So you really need to get on this as soon as possible. So again, just having this conversation, educating ourselves, educating our employers and our fellow employees is a huge first step in this and trying to make these numbers a little bit better. So with that, I will stop my share. Okay, and I'm going to turn it over to the first panel. Courtney, Fausto, Denise, and Lodana, in terms of what actions an employer should take when an employee is having addiction or mental health issues in the workplace.
Yeah, thank you, Nicole. All right, so in terms of our HR panel, like Nicole has mentioned, we have LaDonna Bazzico, who's Employee and Labor Relations Supervisor at Bergen Newbridge Medical Center. We have Denise LaMonica, HR Director, Business Partner, Fausto Micardo, who's co-founder of Sound Advice Counseling and Psychology, and then finally Nicole's colleague Courtney Gassion. So again, let's keep this conversational. But and Nicole, thank you for setting it up. I think you did a great job. I know through the years that I've been here at CINJ, we've had many HR events, and this is such a sensitive topic that, if you're an HR person or a business owner, you got to be careful, right? Because you don't want to violate somebody's privacy here. So I'm going to open it up to the panel. I mean, best practices out there. Maybe you want to share with the group what your respective organizations, how that you conduct these, or how do you handle these type of issues? Who wants to go first, Denise or Udana?
Good morning, everybody. I can chime in really quickly. From a labor relations standpoint, we really do rely on our management. And when I say management, I'm speaking about managers and directors when it comes to employees that may have an issue with addiction. The first thing that we always want our management to do is be very familiar with your staff. If you're familiar with your staff, you'll be able to notice if there's any changes in behavior that could be a result of some type of substance. From that point, we do have processes in place, one of which is being able to administer a documentation that kind of just lets them know, like, this is the behaviors that we are observing. We would like for you to submit a drug test, so on and so forth. And if we do find that the employee is actually under substance, we do take steps to support that employee. We have a program that we use, EAP, which is an employee assistant program. We use a third party company, so it is completely anonymous once the employee does reach that stage. And one thing that I really do love about this program, it did start off as like a counseling program, but it has evolved since to be more of a resource. And what I mean by that is, We do try to hold the employee's hand as much as possible and not just send them to treatment and then leave them high and dry once they've started to clean up their act. One thing that my psych professor, when I was, getting my undergraduate, used to always say that the most dangerous part of recovery is when you just recovered and you don't have the support to sustain the recovery. So that's something from a labor relations standpoint that we would do if we observe that type of behavior.
Thank you, Liana.
I would like to add too to that we start at the very beginning. And what I mean by that, as an organization, we do new hire orientation every other week. And we have our chief clinical officer from behavioral health services talk to all of our new employees about mental health. Not so much because we're, the mental health services that we provide, obviously she talks about that, but about our own employees' mental health. And she goes over, work burnout and stuff like that, and things that if you feel like, you're headed down that path, like what resources we have at the facility, what outside resources we have, who to go to, who to talk to, and just giving that employee who's coming through the door for the very first time, who obviously is not familiar with any of the services that we provide or any of the key employees to guide them in the right direction, and just giving them that support in case they ever should need it and where they should go. We also partner that in our NEO with what we call an ambassador program. And those are directors and managers who have been here for some time, and then support staff that if employees ever feel that they have any issue, whatever it might be, something on their unit, something on their department, something at home, it's a resource for them to be able to go to somebody. So we discuss all of that at our new employee orientation. And then of course it's taken to the department and the units, and they, go into detail on the departments and the units with those employees as well.
So can I ask, just kind of bringing it back? So you think an employee has an issue, right? You're the manager, you're the HR director, you're the business owner. Are you allowed to ask that employee, is everything okay? Do you want to sit down and meet and tell me what's on your mind? Is that okay to do?
I would say yes, and we've done it before. We don't want to take a punitive approach, especially if there is mental issues or if there's anything that has to do with family issues. We want our employees to know that we are actually a team. We work together. We are looking to reach a common goal, and the goal is to make sure that you are at your best self to perform your job functions to the best of your ability. So a conversation is always the first step, and then if we have to escalate, we do. It's unfortunate, but sometimes it happens.
Yeah, and I would say that it should always be, a buzzword is an interactive process, right? And how you determine that there may be an issue is by observing something, right? You have an employee who comes to work on time every day, but now there's a pattern of their coming to work late, or there's call outs, or there's, a call out on Monday after a long weekend or something like that. What's going on? But when you really get to know your employees, right, in and outside of the workplace, because obviously we spend more time with the people we work with than our actual families, and they become your work families, you'll notice some trends and patterns that's just not your employee. So if you keep it interactive, then I agree with Ludana, then you should be able to have those comfortable conversations with your employee, and you should be able to say, hey, I just noticed that something's not right. Is everything okay? How can I support you? What do you need from me? And we practice that at Bergen Newbridge with something called servant leadership as well.
Thank you, Denise. So I guess for Fausto, I know Fausto and Courtney, we're going to cover, Americans with Disability Act, ADA, we're going to cover family leave, but just for Denise, Ludana, and also any of our panelists, anybody on the call, how do you handle when an employee becomes combative, or protective of, what the issue is, and maybe they don't want to share? At that point, as an employer, do you stop? I mean, I don't know.
It's important for us to take our employees' comfort level into account. Sometimes there's just some stories that are too close to the heart or to the vest that they just don't want to share. You try to get as much information as you can, and you just are transparent. Let the person that you're speaking to know, like, I want to help you. I want to work with you. I can only work with you if I have a certain amount of information. If you don't feel comfortable, I understand. And then we can start employing other resources, like I mentioned before with the EAP. Sometimes they just don't want to speak to you directly because you are their boss and you're too close to the situation for them. So an outside party can really help kind of diffuse that combativeness.
Good, thank you.
Right, and I also think that, Americans with Disability, the ADA, right? It applies to employers of 15 or more, and it requires an employee to make a reasonable accommodation that doesn't provide undue hardship. But how could you make that reasonable accommodation for somebody if you don't know what they need us to help them, sort through? So, and a lot of times, unfortunately, when you have this combated employee, again, unfortunately, you'll see the process probably play out more in the progressive discipline, in the labor relations aspect of it, where you
Yeah.
could make it like, a condition of employment, a term, a last chance agreement, that you have to seek treatment, go to an EAP program, follow through, things like that. But I think
No,
that
that's helpful. Yeah. Yeah, it's helpful because I could tell you, Denise and Ladonna, a lot of our members are working remote, right? Depending on the sector. I know it's different with hospitals and healthcare, but you're not seeing your employees as often as you did before, right? So it'd be much harder to kind of detect if there's an issue. So let's kind of go in, because for the sake of time, it's 9:30. Let's go into, Fausto and Courtney in terms of laws that need to be complied with, family leave. Fausto, do you want to go first?
Absolutely. Good morning, everyone. I think I was already introduced. I'm the co-founder and CEO of Sound Advice Counseling and Psychotherapy. I'm very happy with the legislation of the NJFLA. It was enacted in 1989, and it basically provides protection for employees undergoing certain situations. Comparing to the federal side of the legislation, New Jersey is a little more robust because it offers 12 months within 12 months of unpaid leave within a 24-month period. It covers a larger section of it. It was enacted basically with that purpose. But one of the items that really caught my attention about it is that prior to 1989, when this was enacted, employees would lose their jobs because of situations like this. So this is a protection. Now with COVID and everything that comes up, mental health, it's becoming more relevant to the topic of medical and physiological issues. Substance abuse in the legislation was not necessarily point out. What helps substance abuse in this case is if the employee it's undergoing, inpatient treatment by a provider. If that is happening, then the law kicks in and provides the protection to the employee, which basically tells the employer, listen, you can't fire this guy or this gal. You have to make certain guarantees to the individual. And it kind of gives the person the flexibility to work under issues, right? To be more effective, to address the issues that need to be addressed. And one thing that really caught my eye regarding the state level side of it is that New Jersey has the FLI, which is the Family Leave Insurance, because we know that the act was signed unpaid, right? So you can take time off, you can guarantee that you'll have a job, but it's unpaid. Well, New Jersey has the insurance side of it that kicks in and provides the finance, the cash injection to those employees undergoing this situation. So New Jersey is well aware of the situation about substance abuse. Governor Murphy signed an expansive amendment to the FLI a few years back. So our state does recognize the fact that this is a problem. And Nicole very well put out the statistics up there that substance abuse is not just a moral issue, it's really a physiological issue. And we see it a lot in our practice, in our psychotherapy practice. We see how substance abuse is basically purported by other psychological issues that the individual is going through. So it's extremely important, to attack those. But it's nice to have a legislation like we have with the NJFLA for protection purposes.
Thank you, Fausto. Courtney?
So I'm going to just jump in on a slightly different topic, but certainly related. So when we're talking, and just to introduce myself again, Courtney Gassio, and I'm one of Nicole's partners at CSG Law in the employment group. So I'm going to talk a bit about drug testing in the workplace. It's hard to have this conversation without addressing what employers also need to do to be proactive and reactive. If they do have an employee that's suffering from a substance use disorder, or if they are coming to work under the influence, whether that's drugs or alcohol. So we always counsel our clients on the importance of having a drug testing policy in place, either as part of their employee handbook or as a standalone policy. But there are a lot of nuances to what that policy should look like. First, you have to be cognizant of what your state laws require. So we'll focus on New Jersey as I just go through some of the things that need to be considered. But it is important that you recognize what your organization's needs are. What type of industry are you in? Do you have employees that are in safety sensitive positions? And what are the goals that you're trying to achieve through your drug testing policies? So after making those determinations, making sure that you're going to be in compliance with your state and laws, as well as the federal regulations, you're going to want to be able to focus your drug policy on the objectives of reducing accidents and your liability from lawsuits as a result of employees coming into the workplace under the influence. And obviously the ultimate goal is to create a drug-free workplace, which employers still have the right to do. There's four primary types of policies that employers can draft. These are based on the eligibility for these types of policies are based on several different factors, but they are pre-employment testing, reasonable suspicion testing, which I'll talk a little bit more about specific to New Jersey, random drug testing, and post-accident drug testing. These do not necessarily apply to every employer, so you need to be very specific with regard to the type of drug testing policies that would be applicable to your particular organization. It's important that your drug testing policies apply to all employees consistently. You don't want to be drug testing some employees and not others. For example, in the pre-employment testing arena, you need to make sure that your employees are trained on the policy, that they've acknowledged receipt of it, and that they understand the importance of confidentiality as it relates to drug testing. And that is significantly most important for your managers or anybody in the leadership roles that are going to be interacting with employees as it relates to administering these policies, and the importance of maintaining confidentiality of employees because we are dealing with medical information. There are some specific things that need to be considered as it relates to New Jersey, certainly with regard to the legalization of recreational marijuana. This is a very important topic that has gotten a lot of conversation over the last several years. In 2021, the New Jersey State Legislature issued the New Jersey CREMA Act. So that's New Jersey Cannabis Regulatory Enforcement Assistance and Marketplace Modernization Act. And that gives guidance through the CRC, which allows employers to continue to drug test employees for marijuana, even though it is legalized, but there's very specific regulations that apply. For example, employers can now not refuse to hire any person or discharge any person or take any adverse action against an employee solely because that individual has used or not used cannabis off duty, regardless of whether such use is medically prescribed or if it's being used in a recreational capacity. So that creates a lot of complexity for employers because clearly with a drug-free testing policy or a drug-free workplace policy, you do not want employees that are under the influence in the workplace. So it's the balance between that requirement under the state law and not having an employee that's under the influence. So as a result of that, there are specific requirements that were put in through this legislation that allow employees to continue to test. And if they do have an employee that tests positive for cannabis, marijuana, then there are additional steps that actually have to be taken in order to take any adverse employment action. It's also important to look at New Jersey crime as it relates to making employment decisions for applicants. They cannot require an employee or an applicant to disclose or reveal any arrest, charge, conviction, or adjudication on marijuana-related crimes. So the testing itself now these are new requirements since 2021 that were further guidance was provided in 2022. These drug tests for cannabis in the workplace can only now be taken when there's actually a suspicion that the employee has been under the influence while conducting work-related responsibilities. Okay, so during the performance of their work responsibilities, or under the finding of an observable sign of intoxication related to the usage of cannabis, or following a work-related accident if drugs are reasonably believed to have contributed to the accident. So it's only in one of those three circumstances where you can now administer that drug test for marijuana in the workplace. Having the drug test alone turn up a positive result is not sufficient any longer in New Jersey to take adverse employment action against an employee without there being either the reasonable suspicion or the observable sign of intoxication or the connection to the work-related accidents. And those actually have additional requirements attached to them. If you are observing an employee and you have a reasonable suspicion, there is now documentation that's required by individuals that have specific training, and that has yet to be clarified by New Jersey what that training looks like. But there's documentation, there's required or I shouldn't say not required yet, but recommended forms that should be used in making that documentation when an employee is observed to be under the influence. And then that drug test is the second step in the process after the documentation has been completed. So these are a complicated set of requirements as it relates to cannabis use specifically. And it's further complicated by individuals that have a medical certification or they are under the use of cannabis for medical purposes. If those individuals have a registration card, they're registered with CRC, or they provide medical documentation, there is also now a prohibition against employers taking any adverse employment action for employees that fall into those categories. And additionally, it's going to trigger that interactive process that Denise mentioned before under the ADA, when an employer is advised that they have an employee that is subject to medical marijuana regulations, they are now obligated to engage in that interactive process and determine whether or not an accommodation needs to be given to that employee in order to allow them to continue to use medical marijuana and still be able to do their work. That becomes sensitive, certainly if they're in a position that has safety concerns attached to it, they're in law enforcement, et cetera. So this is just a very small snapshot of the issues that are connected to workplace testing policies, cannabis being one of the most complicated areas right now. So we don't unfortunately have the time this morning to go through all of the different caveats that are attached to those regulations. But the suggestion is that with the use of a solid, legally compliant drug testing policy for your workforce, you'll be able to navigate these difficult issues.
Thank you, Courtney. Just one, I mean, for what it's worth, I know since the cannabis became legal I've talked to a lot of our members, unless they're required by contract, if they have a federal contract, a lot of our employers don't even test for cannabis anymore. And
That's yeah.
they're working on, I guess the acronym during the legislative was WIRE, which is worker impairment recognition expert. But a lot to come, I'm sure.
Correct. Yeah, the wire guidelines still have not finalized in New
Yeah.
Jersey, and Tony makes a very good point about any federal contractors or individuals that have federal funding are going to have a whole other set of regulations they're going to have to comply with. So, yeah, additional complication to this topic.
Thank you, Courtney. We're going to go to part 2 of our discussion, which is really the resources and the options that are available. And I'm happy to say we have 4 great speakers. We have Michael Paolillo, who's the Chief Clinical Officer at Bergen for Addictions Treatment, for Bergen Newbridge Medical Center. We have Lisa Centano, who's Senior Vice President of Addiction Services at Care Plus, New Jersey. We have Patricia Toole, who's President and Chief Hospital Executive at Hackensack Meridian Health Carrier Clinic. And then finally, Jesse Stagg Anderson of Horizon Blue Cross Blue Shield. So this is for all of our panelists. And maybe, I'm just going to pick, we want to start maybe with Patricia, if you want to go first in terms of options available, and then we'll go to Patricia, we'll go to Michael, Lisa, and then Jesse can talk about insurance.
Oh, thank you so much. And what an honor and pleasure to be with everyone this morning. So I'm Trish Toole. I'm the President and Chief Hospital Executive at Hackensack Meridian Health Carrier Clinic. And we offer a wide variety of programs throughout the state for individuals seeking treatment for substance use disorder, treating all different substances at all different levels. As we noted earlier in the presentation, pre-pandemic, and really 2019 was pre-pandemic, and some of the surges you were seeing in 2019 were coming off some of the height of the opiate epidemic. There's been a tremendous amount of money infused out of the Purdue Pharma settlements to combat some of the opiate issues, changes in different state laws. I know here in New Jersey, we did have a lot of controls put into place with the number of opiates that could be dispensed for pain management, and we saw so many abuses to that. Post-pandemic, ironically, we have seen a significant increase in alcohol dependence. So we've swung back with so much attention to the opiate epidemic still there, alive, with varying substances that we still do see. But interestingly for us, this new surge in alcohol. And as we all know during the pandemic, it may have been tough to get to your dealer, but it was very easy to buy alcohol. None of at least here in New Jersey, the supermarkets that sold alcohol were open, and the liquor stores were all deemed to stay open during those times. So it's just been interesting us for a treatment provider to see those increases, especially contemporary that we're dealing with right now. For us right now, obviously, we talked a lot about stigma. Fighting stigma is most important. Our employer group talked about it, making sure we talk about it, getting individuals treatment, supporting family members where we have others in the family using or out of control. That affects all of us in the employer group, right? So for us, offering all levels of support and hitting families where they're at, as well as the individuals seeking treatment, is so important, and making everyone feel that this is a normal type of thing, as it would be with diabetes or cancer, that don't never be ashamed of this. You got to speak up, but we've got to support that as a community. So we work on that as a provider and everything we put out there. Our new treatment approaches, contemporary, in order to get individuals back in the workplace faster, as we look at a medical detox, supporting that, especially with alcohol. And in alcohol, you're going to want to have a more safe detox, usually inpatient. You can't die of an opiate withdrawal. You can die of an alcohol withdrawal, right? So those are things we look at every day. But contemporarily, we're building programs to meet you where you're at. Some people can come in for inpatient, some people can stay longer for inpatient, others need to get back to the workplace as soon as possible. So our programs that we're looking at right now may start with a very structured program to get you immersed in treatment, get you the foundational, but now we're building 3, 6, 9, 12-month programs that you have a landing point where you're at, your sustainability in recovery to avoid relapse in that first year. Some of the Yale documents, some of the earlier PowerPoint documents talked that it takes time, right? You just don't go in, you're healed, you're back, right? This is a longer runway. And the programs we're building are, again, to meet you where you're at, recovery in the home or wherever your home is in that moment. Wraparound support for family members that they can also tie into that. So these structured programs might have a virtual component that you can access your therapist when you need them on a day that you're struggling. It may be available for the family members. It also consists of different apps, inspirational quotes, making sure you're connecting in with AA or NA meetings. All of those things that keep recovery in place is very much foundational for us and meeting those contemporary levels of treatment. We also look for more long-acting injectables. I would appeal to our HR teams that design benefit plans that sometimes the long-acting injectables, Vivitrol, buprenorphine type injectables are so successful. Medication-assisted therapies, the thing is, those shots can be more expensive, but more importantly, sometimes employers build their formularies of medications that they're second or third tier in the formulary, which is a higher copay. So they may be part of your formulary, but the copays may make patients and your team members think twice if I can afford that. So it's something I would appeal to everyone when you're looking and designing your benefit plans to know and value what those long-acting injectables do. One shot may last a month, it may last 3 months. It helps with the cravings, it helps sustains, and it's going to get that employee back on their feet quicker and have a longer term runway for success. So I would just put that out there as an opportunity for all of us. Sometimes we think short-sighted when we're looking for cost savings. I appreciate that we ourselves are an employer, right? Looking when we're designing our benefit plans, but really understand the value of that. And when you include them, also do me a favor, look at what that out-of-pocket expense is, because many times we have individuals that may get the first shot when they're in treatment, but they can't afford to keep up with it. So again, something that I would put out there. We're also looking at psychedelics, very emerging market. Low microdosing has been very successful in the substance use disorder. It is in research and design. Hackensack is on the forefront of that, knowing and understanding how we might use small microdosing in the future for longer term success. So it's just one of those other innovations that we're looking at, in addition to mindfulness, wellness, all the things that individuals can have in their toolkit. So those are just a few of the things that we're looking at here at Hackensack.
Thank you, Trish. Michael.
Yeah. Good morning. I'm not sure that Trish left anything out. You covered a lot of area there. So I'll just go with the irony that despite the fact that we have an existing opioid epidemic, as well as Trish mentioned a significant increase in alcohol use, people still do not know where to turn for treatment. And, if you have really good insurance, it's certainly easier. But, just when they're ready, which Nicole, and I'm sorry for your loss, when you went over that small percentage that even gets to the point where they're ready for treatment, they often don't know where to turn. So Bergen Newbridge being a safety net hospital makes it a lot easier for me in terms of getting patients in and really making friends in the field, because we're a hospital. So we're able to take many patients, because for every one of us, there's over 100 freestanding treatment agencies, and they're not able to treat people with, medical conditions. So they rely on us. And quite honestly, if the insurance that the patient has, or if they have no insurance or Medicaid, they often can't take them, and so they depend on us. So we're kind of here for everybody, and the access number that we have, the 24/7 ability, because we have a full continuum, like Tricia, I think you mentioned, like throughout the state, all those services, and that's impressive. And we have many of those same services here at Bergen New Bridge, like under one roof. So you can call up the hotline 20, like I said, around the clock, and they can point you in the right direction to one of the services we have here.
Thank you,
Last thing
Mike.
I want to add is I'd like to say we have no barrier access because, as we've learned, this is life or death. And so if a patient calls and they want help today, and I tell them, come next Friday, they may not make it here.
Thank you, Michael. Lisa.
Hi, good morning, everyone. Just to go along a little bit with what Mike had said, partnerships, I can't highlight that enough. I think that we all have something to offer. Sometimes people can't miss work, right? So they can't go to an inpatient type of program. Here at Care Plus New Jersey, we do have an ambulatory withdrawal management. So if you have uncomplicated opiate withdrawal, it's actually on an outpatient level. I will say a couple things when it comes to finding the resources. A lot of times people call like randomly throughout the community and they say, well, where do I even go from help? I get calls from friends of friends. There's a couple different ways, partnerships, right? Then you have an IME access center, which is a toll-free number. It's 24/7. It's a service of Rutgers University Behavioral Health. And their main goal is to refer people to treatment. And then there's also a website from the Division of Mental Health and Addiction Services where it lists all treatment programs that are available for care. But basically just really being available to anyone that calls, because sometimes it's not going to come through your organization. It's going to come in different ways from friends, family members, and just really knowing where in your partnership to make those referrals so the person gets better.
Thank you, Lisa. And finally, Jesse, sad reality here is all the options that we've talked about, that there is a cost associated with it. And I know, both employees will have to factor in, but you as our insurance rep today from Horizon play an important role. But so the floor is yours, Jesse. Thank you for being here.
Thank you. Trish, I love everything that you said, especially the fact that one thing that's often missed is that the employers create and write up the plans. And we will follow them and do what you do as directed. But if you make things high cost or you decide that things shouldn't be covered, which happens, we have policies where alcohol dependence can be covered, but not, other drug dependence. You are in control. You as the business owners are in control of what you put in your plans and how you choose to help your employees and their families. So as Trish and Michael and Lisa explained, there are a vast number of levels of care, starting with, traditional outpatient therapy around substance abuse to maybe get you some insight and figure out if you do have a problem, if you do think you're ready to get some help. There are many levels of care that don't require insurance authorization, such as outpatient. There is a substance abuse mandate law in the state of New Jersey where if you have the right kind of policy, again, it depends. It's not Medicaid, it's commercial insurance. There are 28 days up front that do not need to be authorized. They just need to be registered. We need to know you're going, and then we just say, go. We leave it to the professionals in the facilities to tell us what is needed. And then after that point, we start doing medical necessity reviews. We also have EAP services. We also have peer support services. But as has been pointed out, the hardest part is that first step of saying somebody needs help. Who do they call? You can always call us. We have outpatient navigators who can help clinical folks on the phones who can help figure out the most appropriate level of care. The employee is going to need a level of care assessment somewhere. All of the facilities represented on this call are partners with Horizon, so please send your people to any of them. And then call us. Treatment first, insurance second. That is the role. As Michael said, people die. as Trish said, people die, right? Alcohol withdrawal can cause death. Benzodiazepine withdrawal can cause death. Opiate withdrawal, you'll want to die. You won't die. This is very serious. This is as serious as it can get. So please reach out. When in doubt, feel free to call Horizon. We are staffed with clinicians 24/7 who can answer questions. And if anybody has specific questions and they want to reach out directly, that would be fine as well.
Yeah, thank you, Jesse. Well, we packed a lot in. We have about 3 or 4 more minutes. Any questions from anyone?
I just, not a question, but more a comment, and I'd appreciate any feedback here. I experienced with my sister that obviously it was hard to get her to go to treatment. And I did appreciate any type of program where it was just walk-in. I think it's, so if one of the providers want to speak to that, what they do in their programs to just get someone in the door and provide that initial access, knowing that hurdle, that first step is often very difficult for someone with the disease.
I just want to add, I can respond to that, but one of the newer things we're doing that's pretty exciting, and we'll see how it plays out, is often the family member is the first to call. And most agencies, as you know, will tell you, I'm glad, thank you for your concern, but we have to hear from the patient or the client themselves. So what we've been doing is inviting the family members in, establishing that connection. So when the person is ready to come, we already, like, that barrier has been broken down. So there's already that connection. So we have a recovery center. We started using that for the families to come in and get, this way they know where they're going when they're trying to convince their loved one to come into treatment. There's already that knowledge of what, how to access treatment. So it's new, we're trying it, but like I said, I'd like to be no barrier, and even trying something like this is definitely worth. We have to think outside the box. So Nicole, you would have been able to just come in.
Nicole, if I could just also add on to that, as someone that lost my stepdaughter in May to an opiate overdose, I would say this, like, when it comes to family, it's always the unconditional love piece, right? But without enabling and having boundaries. And one thing that we do offer is a family support center. It's a free grant where people can come in, and basically it's built off the CRAFT motto, which is the community reinforcement and family training. So it's really like leading the family in the right direction. Like, when there are poor behaviors going on, we're not going to enable that family member, but we're also going to help the family member to meet their loved one where they're at, and hopefully through helping the family help themselves, we're hopeful that will then have an impact on their loved one. And there's also many support groups for family members. There's Al-Anon, there's Nar-Anon, and there's also a family 12-step type of program that's designed as well. So if you
I was going to say the same.
if you can't see the person right away, hopefully you can save the family. Yeah.
The Al-Anon meetings, the AA meetings, the Narcan, they're all the time, and they're free and they're everywhere. So if there is a family member who needs support, I'm sure that they could get themselves, if they were ready to a meeting where they would meet like-minded people in the same boat and get some support and some resources.
That's a great point, Jesse, because, during COVID, I had to meet, we had a lot of Nar-Anon and Al-Anon groups, and had to meet with them, and they went virtual. But people, some people were okay with the virtual, but some people really wanted to get back together. And so Deb, who was very flexible, very early on, let us bring the Nar-Anon and Al-Anon groups back in. And they're well attended, and like Lisa said, extremely important. So.
Yeah, and I can't add too much more than, my colleagues have already offered in family support, as well as we offer 24/7 walk-in to our admissions department here. So we're always open and available. But I think what we all do know, and probably why we're focusing again on that family support, is if the patient isn't ready, it's not going to work. I mean, we see many people bring a loved one in, and it doesn't matter if it's a walk-in at 2 a.m, right? If they're not ready, it's not right. They're just going to leave treatment, right? These are consenting adults. So everything we can do to find all of this wraparound support, that we can support the family or the individual when they are ready, whether they come to our facility or another facility, it's a win. Right. I think we all fight stigma, all of us that are here on this call every day. And the goal at the end of the day is it may take multiple times to get them to the end, but being there to support it as a village and a community of providers is what you're hearing.
One thing that we're doing at our practice is basically promoting to our clinicians the fact that the minute you start a session, a psychotherapy session, and you identify a situation of substance abuse, we're actually partnered with a psychiatric clinic so we can tag team, because this is time of the essence, right? So identifying things at the right time and speedily will produce great results. We believe in the whole program, in the whole assessment. So you know, identifying those things. And I think managers and supervisors need to have better training or more training to get to identify these issues a little more when it comes to the employee level and so forth. But what we do at Sound Advice Counseling is basically tell our clinicians, listen, the minute you see something in your assessment, just, you know, if you see something, say something, so to speak.
And just to add to that, I used to actually work or volunteer for a church when I was younger. And one of the things that they used to do for people that had substance abuse issues, but were not ready for counseling, they would provide family counseling, because the thought process behind that was a lot of people that do have substance issues or substance abuse issues, it's related to some type of mental issue, which could be traced back to trauma. And trauma typically happens within the family. So the counselor that was working at this church that I was working under at the time, his thought process was, if you are able to provide a remedy for the actual issue instead of just for the results of the issue, it can bring the person that may have shame around their substance abuse to a comfort level where they're more willing to take the counseling or the treatments into their own hand and stand on their own 2 feet afterwards. So, you know, it's just a little creative way of trying to reach the person without going directly towards them, because sometimes the direct approach can cause them to clam up a little bit.
And I just
Yeah.
have a closing comment in terms of the slide we saw from Yale, the brain imaging. This is not a disease that is cured in 28 days. And so I would certainly recommend not minimizing the importance of Alcoholics and Narcotics Anonymous, to go somewhere where you can identify and even help other people that are dealing with this disease on an ongoing basis is very, very valuable. And the saying that the opposite of addiction is connection couldn't be more true.
And I would put from an employer perspective that if your organization has an EAP program, that you or somebody who are having, you know, struggles because of your family member struggles should reach out to your EAP program and see what services are available to help you, you know, cope with whatever is going on in the situation.
I have a question. Yes, we do have EAP. Good morning, everyone. I'm Jackie Jones from the County of Essex. I'm the HR director. I know we mentioned EAP, we have that, but how do you handle when you have law enforcement that does not want to go through the part of talking to EAP? Would you advise it helpful and it's more cop to cop kind of thing, and just making them more comfortable to say something? Because a lot of them won't say anything until we start to see signs, and then I get alerted to send them for fitness for duty and situations like that. But what advisement would you give to help to assist the law enforcement side for corrections, our sheriff officer, prosecutors, to say something? We had one officer walk in and just turned her gun over voluntarily, and we reached out and got some, you know, help for her. But what are other ways you can advise us how to approach that on the county side for law enforcement?
Yeah, I mean, I would say that you unfortunately would have to make it more of like a disciplinary, a labor relations, and make it terms, conditions of employment. I mean, I don't know if you have union employees, and obviously there's union contracts involved if you do, similar to what we have at Bergen Newbridge, but I think that that would be maybe not the easiest, but one of the more approachable and manageable ways to deal with the situation and make it, like I said, terms of employment and conditions to continue employment.
Yeah, that's true, but I don't want it to feel like I want to get them to where being comfortable to help address it. Like that part, we know the discipline part, that's the protocol we follow, but more so just helping them feel more comfortable to, say something, to be okay when we approach them.
Jackie, I'll just jump in real quick. I want to touch on something Lujana said earlier, which is that sometimes getting help internally is not always the best space for an employee. It's not where they feel the most comfortable. So that it may be in the circumstances that you're describing a situation where they do have to go outside of the organization, right? And I think then that's when it becomes important that you have the type of partnerships with a lot of the organizations that are on this call today, where there's a relationship there. And if you have an employee that's either being non-compliant or is just not comfortable with going to an internal EAP, that you have providers that are available externally that can offer those same types of services where there's sort of that buffer, they're one step removed from the employer, and they have a greater level of comfort. I also do think Cop to Cop is a great resource for people in law enforcement. But I think that forming those relationships with external providers is really important for both public and private employers to have referral sources that are not that for employees that can't be helped internally.
Thank you so much.
This is Jessie. If I could just also add, there are first responder programs where everyone in the program is a first responder. So maybe not all cops, but cops and EMTs and corrections officers and that sort of thing. The one that comes to mind right away is through Penn Medicine, which is not in Essex County, but I assume not all of your employees live in Essex County, even if they work in Essex County. But there are, first responder programs where they would hopefully feel more comfortable. And maybe if that was introduced, the concept of that was introduced to them, that, it's confidentiality is everything, right? It's everything. So they need to know not only is it confidential because it's substance abuse, it's confidential because it's your people, right? It's your brothers and sisters. So I would recommend looking for a first responder program as well.
Thank you so much.
Sure.
And Jackie, I just also wanted to say, I know it's in most counties, but Bergen County has a robust crisis intervention training program that's for all law enforcement. And basically we speak about kind of like the concept of addiction, co-occurring disorders, and all different things that could be going on, just whether it's de-escalation, how to handle someone if they're escalating in public. And they do have a cop to cop program, because usually it is also a cop that has gone through a similar experience. And when you do have those peer type of moments, it does show that they're more likely then to go seek help from an outside provider.
Okay.
Tony,
I would
if I could
probably
just
say
add
also, if I can
Okay.
jump in very quickly, I'm so sorry. I
ahead.
agree with Courtney and everyone. To Jackie's question on a county level, I believe that people feeling comfortable to speak to someone, and what Courtney says, to be external, right? And external resources rather than internal, opens up more the comfort level to open up and make this really preventive measure rather than damage control, right? Employees they need to know that you just don't talk to someone when you think you have a problem. You talk to someone because the person is available at all times for whatever you think you may need to talk about with someone. So I think having that resource, not only for the county, but for all employers, and having employees have that option to dial someone or go to a place if they just feel they just want to talk to someone, that could be a preventive measure as well, rather than damage control.
And I want to, if I could just follow up, that's exactly what I was going to say, Fausto, is that what we're doing today amongst our group for employers is, I think, really important to be doing internally in organizations too, for employees to have preventative wellness programs in place that may involve things like yoga and, exercise, programs and things like that, but also on the mental health side, and make this a conversation in the workplace that employees become comfortable having, right? So this is to Nicole's point about removing the stigma. I think that's the greatest tool in our toolbox, is to make the discussion of mental health and substance use disorder part of our workplace conversations, where employees can find safe spaces at work to come and have these conversations. So there are, things that can be done internally and within an organization to start those kinds of conversations at the employee level as well, not just for us in a professional setting like this.
I was just going to add the importance of reducing stigma. Many families they come to me and they said, I was hesitant to get treatment because I didn't want to be judged. And so we not only have a stigma-free flag raising today, I believe, Deb, right? But we are actually stigma-free. We want people to come here and feel comfortable. And, without that, people are resistant to go to treatment because they feel like they're going to be judged. And the CIT that Lisa spoke about with the police officers, that has been so helpful in reducing stigma, because they're hearing from people in recovery from substance abuse. They're hearing from people, in recovery from, mental health disorders. And so the stigma here in Bergen County, certainly we're doing everything we can to reduce that.
Oh, this has been a great conversation. Jacqueline, I know you put your email address in the chat box. So if you want to connect with Jacqueline, please take a look at her email address. And then I know Fausto just posted his website, but been a great conversation. This has been recorded. So we will send this out to the broader membership, and we'll probably post it on our website. If you go to our website, we have virtual events listed there. So great conversation. Appreciate Bergen Newbridge Medical Center, CSG, and everybody that joins today's call. Please be safe, and look forward to seeing you at the next event. So thank you, everybody.
Thank you.
Thank you.
Bye.
Thank you, guys. Have a good day.